The patient chosen for this case study is RS. RS is a male in his 60s who was a direct admit to the unit after being emergently intubated at another facility when he had uncontrolled swelling in his neck after a radical neck surgery. He needed this surgery because he had cancer metastases to his neck. He was vitally stable during this shift despite his medical complications. His nursing assessment, his airway was patent. His lung sounds did change to an expiratory wheeze in the second and third assessment, likely from the metanebs and albuterol nebs that he was receiving. His capillary refill was less than 3 seconds in all extremities. Muscle strength was equal bilaterally, neurologically intact following all of our commands and nodding appropriately to questions. His pupils were equal, round, and reactive to light. He had hypoactive bowel sounds, which was likely because we hadn't fed him in a few days. His skin was warm, dry, and intact, an appropriate color for his race, despite his left neck and left chest. Those were not within normal limits. His left neck had a skin flap with staples present, and it was definitely not approximated on the left lateral side. It had quite a large crest of blood and small amounts of yellow blood-tinged pus oozing from it. It was hot and painful to the touch, swollen and red in color. His left chest was the donor site for the skin flap and had an approximated incision held together by staples, had a large amount of fluid underneath his skin extending from his left sternal border to his left axillary area. He had some blanchable redness on his coccyx. We weren't too concerned about that. His heels were within normal limits, warm, dry, and intact, an appropriate color for his race. His first assessment in air bolus was heard just below his sternum, not over his stomach. So we advanced the OG tube and got an x-ray to confirm, and the OG tube was advanced into the stomach. The second and third assessment, the air bolus was heard in the stomach. So as nursing diagnoses, we have inefficient airway clearance related to a narrowed trachea as evidenced by swollen left neck and a need for an ET tube to maintain an open airway. Imbalanced nutrition related to NPO status without tube feeds as evidenced by low potassium levels and no nutrition given for 2 days. The risk for ineffective coping related to the increased stress on a critically ill patient. His short-term and long-term goals, you can read them here. We wanted him to keep his invasive airway and keep an open and patent airway. We wanted to start tube feeds, and we wanted him to keep his effective coping skills by leaning on his family and medical team. The plan for RS was a prioritized plan and was created to first assess and maintain an airway, breathing, and circulation. Then his other body systems would be addressed as needed, including his neurological status, lab values, skin, nutritional status, and psychological needs. He had some abnormal labs, which we did address with the physicians, especially his low potassium levels, which we did replace with IV and oral potassium during this shift. He did try a CPAP trial, but that didn't go very well, and he became acidotic and had mild hypoxemia. So they switched him back to pressure AC and increased his rate of breathing to 16 so he could try to breathe off some of that CO2. So we did start tube feeds during this shift. We started Replete, and that went very well. He had no residuals during the entire shift. We were able to increase his tube feeds by 10 at the end of the shift, and we expected that to continue to go well throughout the next day. So for his evaluation, he maintained his invasive airway, and we had interventions in place to maintain that airway. He had bilateral soft wrist restraints. He We also did all of our charting in his room for closer observation. We checked the length of his ET tube every 4 hours, and he did have a daily chest x-ray. So that was maintained, and that's a great outcome. The breathing and circulation were closely monitored, and both remained adequate. We addressed his lab values as needed, and his coping remained adequate, and a chaplain was able to come to the bedside and visit with RS and his family. He was on medications that were appropriate, and we didn't need to address a medication for his increased stress because he was already on Protonix to prevent a stress ulcer. If you have any questions for me or you'd like me to send you my reference page, you can email me, and my contact information is down here at the bottom. Thank you.